consulting, and today we're going to be looking at the topic of mental health. I'm really pleased to be joined by Dr Lizzie Croton, who's a bit of an expert in the area. Welcome, Liz.
Hello, hi.
So, Lizzie, you've been very involved in providing mental health care, both within primary care, but to GPs as well, and through using video consults. Can you tell us a bit more about your experiences?
Sure. So I'm a GP in a practice that is quite close to the University of Birmingham. So we have quite a few students with mental health problems, unfortunately. But that does mean that we have had a lot of experience with certainly managing mental health problems and talking to people who are experiencing emotional distress. Also, a couple of years ago, I worked for a telemedicine company doing digital consultations, of which a sizable proportion of those were mental health type consultations. And I do a bit of work for PHP as well, which is the Practitioner Health Programme, which from this week has gone remote. So we'll be doing the consultations using digital platforms such as the ones that are commonly used.
Brilliant. Well, that sounds great. And actually, mental health consultations are somewhere where the video, in my experience, really brings added value, and patients really seem to appreciate it. With some of the more physical things, sometimes it's hard enough, in my experience, to get a good enough quality image. But for mental health, just being that person at the other end of the video screen really seems to make a difference to patients. Have you found the same?
Yes, that we have. I mean, sometimes we find that patients don't like seeing their face on the screen, particularly if they're feeling a bit, if their self-esteem is a bit low, or they don't particularly want to see their face. So that can be a bit of a problem sometimes, but we can get around that by sticking a post-it note over the screen, or that's what I tell them to do.
Good idea. So, actually, I find it really distracting seeing my face on the screen. I never thought of that. That's such a brilliant idea.
Well, quite, yeah. I mean, I don't like seeing my face either, so I always seem to make very strange facial expressions on cameras that I don't realise I do.
It's odd, isn't it? And it's so easy to get distracted by that rather than by the patient. But anyway, you put together a presentation for us, so I'm just going to flick onto the first screen, which has got some practicalities about doing it. So let's talk us through.
Sure. So, I mean, basically, the first thing to say is that you can do a mental health consultation on the phone or on video. I think video is often much more helpful because it is a bit like, as far as possible, having the patient in the room with you, and you can see their face, and you can also see the facial expressions. And I think there is that person-to-person connection, which is really important with mental health consulting, that the person can see there's another human being on the end. If they already know you, then they already have that connection. So that can be really useful. But also I think phone can be helpful as well, because if you know the patient, then you tend to know whether they're well or they're ill, simply by the tone of their voice or how they come across. So that's really useful as well. I think I'll just talk through, really. Is that okay?
Yeah,
just kind of go through some of it.
And it's interesting, as we're chatting, actually, that little bit of a lag that you get on a video consult, I can feel it coming in. We're using Teams to do this, and it is interesting when I say it's just not coming in quite the right place. And interesting, isn't it? Because that's so often a feature of our consultations with patients too, using video.
Yes, and that actually nicely brings us on to the next point, actually, with kind of some tips on history taking. I think the key with talking on the video is just allowing the patient to tell their story, as it were, rather than kind of asking them lots of questions, because often there is that lag and that can be a bit disjointed, can't it? So when I'm talking to a patient, I like to kind of ask them, what's brought them here or how they are, and just kind of let them talk, really, and keep the connection. I mean, it's really important when you're talking using a video platform, and I think Becca, you covered this in your first video, is rather than looking at the screen, it's important to look at the camera, the actual camera, because then the patient will get the impression that you are looking at them as opposed to looking at your face on the screen, if that makes sense. And also to smile. and listen, and try and kind of keep your head as still as possible. So just kind of allowing the patient to talk, really, and asking them how they are, and then listening. And I mean, a lot of the cues that you'll get are very similar to the ones that you'll get in a face-to-face consult. Really, you'll be able to tell, you know, if they're anxious, do they appear tense? You know, are their eyes darting around? Are they restless? Are they, you know, for example, cracking knuckles? Or you may not be able to see if they're tapping their feet, but that kind of thing, really. You know, what are their thoughts like? Are they sort of catastrophic type thoughts? Are they all or nothing thoughts? You know, everything's terrible. Similarly with depression, you know, you'll get an idea of that. They may not want to make eye contact so much, because often depression and shame and, you know, being seen, they tend to kind of go together. Their voice might be quite flat. They may be quite monotone. In that respect, it might be better maybe not to make so much eye contact if somebody is in that kind of frame of mind where they're not really wanting to make eye contact. Sometimes staring at them can be a little bit too much. So maybe just, you know, looking away or looking slightly away from their face can just kind of help them engage. Paradoxically, I quite often do that when I'm speaking to patients who, you know, have trouble with eye contact.
And that's such an important point with the video, isn't it, Liz? Because actually it is easy to kind of stare at the camera like some sort of, I don't know, zombie or something. And actually, normal conversation, you look at people and you look away again, and it's just the same, isn't it? And it is important not to be kind of like this wide-eyed. Is zombie the right word? I'm not sure, but you know, using those normal conversational strategies, look at them looking away, and like you say, particularly with depressed patients, not freaking them out with too much eye contact.
Absolutely. It can just be a bit much, and try to avoid too much head nodding as well. I find that is off-putting sometimes. It's very natural. It's just allowing them to talk, really. You know, how are you? What are you looking for today? How are things going? Also, if people are very stressed, just kind of asking. This is the kind of difference between, I suppose, a medical student taking history and someone who's been, I suppose, doing it for a while. You don't tend to have to ask lots of questions, because the patient will generally tell you what you need to know if you listen. As William Osler always said, listen to the patient, because they'll tell you what you need to know. So that's kind of really important. It's just to kind of allow them to talk. And you know, you're listening for things like you know, they may well talk about their, you know, their functioning, how they're getting on. They may well talk about things that are bothering them and what's worrying them, and you can focus in on those in the consultation. You know, so they'll kind of give you clues all the time if you listen. I always tend to ask directly about things like suicidal intent. I think that's really, really important. And we all have our own ways of doing that. I tend to say things like, you know, have you thought about, you know, have you ever felt so bad that you've thought about harming yourself or made plans to end your life? I'm quite direct about that, really. And it's. Say that again, sorry.
So how does that go down with patients? Because that's something a lot of people worry about, is just how to phrase those questions. And like you say, that is very direct. How is that received by patients in your experience?
I think if it's asked in a kind of a soft way and in a concerned way, generally, I mean, the evidence seems to suggest that asking about it doesn't increase the risk of people doing it. And I think sometimes people are actually quite glad to be asked, particularly if it's somebody.
Isn't it? If they've been thinking about it, actually to be able to talk about it and have that permission, people already seem to value that.
Yeah, it's normalizing it, isn't it? Because it's actually very. I think I read a statistic somewhere, and I can't remember where I got it from, but something like 50% of the population have had suicidal type thoughts at some time. It's a really high number, actually, and not everyone will have, you know, a diagnosable mental illness, but it kind of makes sense if people are not feeling good, that they may well have those kind of thoughts. You know, it's about normalizing it, I think. I often tell patients that they're incredibly common, and they make sense in the context of what they're presenting with, really. And there's also a massive difference between suicidal type thoughts and actual concrete plans as well, which is the next part.
Yeah, which we really all start to worry, isn't it? So yeah, tell us more about that.
Well, I tend to ask about, have they had those kind of thoughts? And NICE doesn't recommend that we use specific suicide type scales, but for me, I like to get an idea of, are they thoughts? Have they materialized into plans? If they are plans, what are those plans? And how likely would the person be to act on them? What would stop them doing it? So these are kind of things like protective factors, because often people will say, well, I've thought about it, but I wouldn't do it because of X, Y, or Z. Or you get an idea that the person's thinking into the future, they're making plans for the future. And that can often kind of help you make a sense of how likely this is to happen. It's quite a difficult area, I think, because people can say one thing and do another, and I don't think it's impossible to be completely certain about it. And I think the more we know the patient and the more we know how the patient responds under stress, because when people are stressed, they tend to behave in more rigid ways. I suppose the easier it may well be to predict what they're going to do next.
Yeah, and this patient group is one that really does benefit from having the same person manage them, aren't they? And whether that's via video or face-to-face, no matter how we do it, actually having that person that knows them can make all the difference.
Absolutely. It's that human connection, isn't it? It's that and that sort of non-judgmental kind of listening. That kind of this is kind of very normal. How can we help you with this? There's something else I was going to say as well. The other thing about suicidal thoughts, sometimes if people are having a lot of thoughts, they can't kind of get away from them and they're very intrusive. That's more worrying as well.
Okay, so actually having loads and loads of thoughts rather than the sort of odd it passing through your mind. Yes.
I mean, I will be mindful of patient confidentiality here, but just thinking of patients that I've spoken to recently, there was, if a patient is planning to go and this isn't an easy conversation, so just be aware, sort of trigger warning, as it were. But if someone would be planning to go and jump off a cliff or something, and they'd already booked the train tickets to get there, that would be far more worrying than someone who was just having those kind of thoughts, for example. So it is actually allowing people to kind of talk about this and listening and saying, that sounds really hard, and what can we do to help you with this? And it's kind of important, however difficult the consultation is, to try not to sort of appear calm, which is easier said than done, because it can be quite panic-inducing if people are verbalizing these plans. But it's okay. That sounds really hard. How can we help with this? Or if people have done this before, what stopped you? What would be, what would stop you doing this? What would keep you alive? And it's important, I think, to be mindful that, because often if people are very stuck in these kind of states, if you come across as trying to talk them out of it, that kind of doesn't help. So you somehow have to kind of meet them in the state, as it were. You almost kind of have to kind of join them there and then kind of help lead them out, if that makes sense, rather than saying, yeah.
Yeah, how practically do you do that, Liz? Because I kind of get the concept, but kind of thinking through, well, what does that look like? What language would I use? That's always the challenge. And I'm one of those people that sort of, you're in the moment, you think I need to say something appropriate, and everything appropriate goes out of your mind. So what do you say?
I think you kind of help the person accept that that's how they feel at the moment, and that's okay. So it's very normal to feel like this when you have X, Y, and Z. That must be really hard. Do you think it's something that you would carry out? Have you made plans? Okay, sure. And obviously, and then you could say something like, that is there anything that would stop you, or have you, is there anything that you have to live for, or have you felt like this before and it's been different, or something like that? You're just trying to kind of move them out of that state.
Okay, so the empathy, the probing, the listening, and then
Yeah.
taking them back to when they felt like it before, and sort of exploring with them the good things that stop them doing it, or is that not quite?
Yes. Yeah, you're looking for exceptions basically to when they haven't felt like that. Sometimes if people are very, very stuck, you just have to kind of keep with them, really. And in those cases, it may well be more appropriate. You wouldn't necessarily want to just manage this on the video and close the call, as it were. You may well have to get other agencies involved. But a lot of it is about relationship, and the same person seeing the person each time and listening, and it can take quite a lot of time.
And I guess that is the challenge, isn't it? Particularly at the moment when everybody in all the services are so pushed. But actually, this is an area where putting that time in at the beginning can stop the patient bouncing from service to service, and is a really good investment of time. What are your views on that?
I think that's absolutely true. I mean, we have patients who, they because they know the doctor and they know them from, for years, then just a brief chat can often shift a lot of these states, because it's that human connection. I was, I'll move on, but yes, it's about, it is about listening and allowing the person to tell their story. That's very important as well. And respecting that story as well, respecting that that's where the person is at that moment, because nobody really likes being told that they're wrong and they shouldn't feel like that. And it's because these things are very, to the person, it's a very painful, stuck kind of, this is what I'm going to do kind of thing. And actually often having that connection and having that recognition of the story, and actually saying, well, we're with you on this, it's okay, that can really help.
Is that the quote you referred to? Is it Osler about, was it to like heal sometimes? How does it go?
I think it goes to comfort always. That's the last bit.
Yeah, that's the last bit, isn't it?
And to help sometimes. Yeah, and to help sometimes. Yeah.
You can see how well we've prepared this. It's a great quote, and that's another one I really like about no one cares how much you know until they know how much you care. And then we can't fix everybody, but we can always be there as another human, sharing in their story and doing what we can to, I guess, that full of cliches today, the doctor as drug concept as well. But anyway,
yes, Valent, yes. Absolutely, Valent. So I suppose the other thing practically is, like, if you feel, if the patient does seem really stuck and they're kind of really intent on doing something, and you don't feel that you can actually get much headway on the video, for example, if after a while they say, okay, well, I don't really, I'm feeling a bit better now, thank you, and you might, I think if you've got any doubt, then you need to be doing something else, which might involve contacting the crisis team and asking them to assess the patient. And certainly in this current COVID climate, I feel it would be better face-to-face myself. That's just my kind of bias on this, because I think face-to-face connection is superior to video, really. But I do think you can do an awful lot video. But I think with something like this, I think being in the room with someone is really, really, really powerful. So you may well be able to refer directly to the crisis team if you haven't seen the patient face-to-face. And that may well involve, getting a phone number and ringing the crisis team, and then finding out where the patient is, and then ringing them back, and then checking in on them later on.
And I think that point about the crisis is really essential, because being an out-of-hours GP, getting people referred in the middle of the night has always been a challenge, and you have to go and see the patient face-to-face, even though it doesn't add very much. And actually, in these times, I think it is well worth talking to your health board, your CCG, your LMC, and getting some support to be able to send these patients following a telephone or a video consult without putting in the extra step of a face-to-face consult, because we do need to keep that risk down, both for patients and ourselves, and minimising face-to-face consultations. So talk to your health boards, talk to your CCG, and try and create those pathways so that you're not having very long, complicated conversations with psychiatrists or crisis teams that want people seen face-to-face.
Absolutely. I think that's really important. And I think we should really try not to send people to A&E. Unless there's a really, really good reason and we can't sort it any other way, or calling the police. Obviously, if that's needed, then that's needed, isn't it?
The last resort, not the first option.
Yeah. I mean,
risk. Have we covered what you wanted to say on that section, or is there anything else?
Well, I think the thing is that we're very, as GPs, we're very familiar with managing this sort of thing in practice, and suicide is one of those things, and suicidal ideation is one of these things. It's not an exact thing at all, and I've certainly lost patients through suicide when they've told me that they wouldn't do anything. So it can be very, very unpredictable. So I think we do have to err on the side of caution, and sometimes if you are doing a video consult and you kind of have this feeling, actually, I don't feel good about this. I don't feel that actually we're I'm not sure whether this patient is going to do something, then we do need to make sure that there's safeguards in place, such as getting the crisis team involved. It might be that we check in with the patient in a couple of days. We need to consider things like, access to lethal means, how much medication they've got, social connections, that kind of thing. It may well be important to get other family members involved. I think that's really important, with the patient's consent, who can kind of keep an eye on the patient, keep an eye with medication, that kind of thing. So it's a feeling, really. It's not an exact science, and I think it's always best to err on the side of caution, and do what you would in a normal consultation, and document very well as well. Document what was said, what the protective factors are, what the plans are.
That's so important, because a lot of video platforms will not record the call in the same way that calling out from your surgery might. So it's important to go that extra mile in making sure you've documented thoroughly. Yes,
absolutely. I mean, I think a key part of this is prevention as much as possible. So it's and that's what I wanted to talk about next, actually, is getting people, because if people have, say when they get stressed, they've had these sort of suicidal type thoughts, there's been suicidal or self-injurious behaviour before, and we've all had patients on our list like this, and this is kind of, they present in crisis, and I think a really, really key thing is in these times is prevention. And I feel that I really can't do this justice unless I mention safety plans. Are you familiar with this?
Yes, I am. But I haven't done it off the hoof with patients, not in a sort of formalised or structured way. Have you got a formal way to capture this, or a template that you use?
Yes. There's one on the internet called Staying Safe.
Staying Safe. And Liz, if you could pop that in the comments after this video is uploaded, a link to that would be really helpful.
Yes. It's credit Dr Alice Cole-King, who is a Welsh psychiatrist, not far from you, actually.
I think I saw her on Twitter.
Yes. She was talking today, actually, in an online summit, and the Staying Safe is a accessible platform where patients can go on, and there's all sorts of tips about creating a safety plan. And the idea is that they fill it in when they're not feeling like this, and they look at things that help in this sort of situation. They may, want to do it with friends or relatives, and they basically go through things that help, things that make them feel better, emergency contacts, and they come up with a plan. So it's almost like a plan before this happens, so that they can start to recognize that, you know, they're kind of going down that path, and they can start to put some of these things in place. And it's a really, really, really good, really accessible platform, and it's certainly helped a lot of my patients. And they quite often they'll either download it on their phone, or they'll kind of carry it around with them in their wallet. I've had some people that have done that, and it's about empowering people really, and actually helping people manage themselves internally, but with having that sort of sense of agency. Because that's kind of what
important, isn't it,
yeah.
at this time, that kind of empowering the patients to do stuff, not coming back to us, because it's unlikely that general practice is going to have the capacity. And the more we can get people to help themselves and support each other, the better, really.
Yeah, absolutely. Because this is it. I mean, you've always got to look at social connectedness as well with these patients, because usually there's something wrong with it, in that people don't have, or they don't kind of feel part of a social network, as it were. Or they may have lots of friends and they don't feel that they can talk to their friends. So there's usually something not quite right, if you ask about this kind of thing. And so this is why it's really, really important to encourage people to not necessarily, you know, talk to their friends all the time about their mental health, but actually just kind of making connections with people, ringing people up, asking how they are, you know, that kind of thing, really, so that they have got people that they can contact. Because we do have students who the only people they talk to is the wellbeing counsellor at university.
And that is so isolating, isn't it? If that is literally the only person you know.
Yeah, or the GP, and that's, you know, it's good that they're talking to someone, but again, you know, it becomes very stressful, I guess, for those two people to kind of support that person, because nobody can support anybody like that, can they? They can't be there all the time, and usually, you know, if somebody, you know, hasn't got the time, then that person can then end up feeling very sort of unwanted and not, you know, not important. So it's so important to cultivate social relationships, and that might not necessarily be family, because sometimes people don't get on with their families, but, you know, it could be friends, it could be another adult, you know, like a family friend, a sort of parent figure. I think, you know, there's a concept of the wise friend, you know, so somebody who's perhaps got more life experience, who's been on the planet a bit longer, who the person can approach, put the phone number down on the safety plan, and just have this kind of network of people. I mean, there are also kind of mental health support groups. They have their place. They sometimes can become a bit of a, if somebody gets ill, then, you know, it can become quite distressing. So sometimes they're not always the best. They can be very helpful, but sometimes they can be unhelpful as well. So I think it's about what works for the person, isn't it?
And it sounds like the safety plan actually can catalyse some of those conversations about, say, the wise friend. I don't think that's something I've suggested to a patient before, but actually having it there on the plan, going through it with them, I guess can help put those pointers to other sources of support away from the surgery and away from more formal sources.
Absolutely, and you know, and having these kind of attachments with people is really important. The other things that are really important if people are isolating or they're not going to work, I have to credit Garner Thompson, who's a mentor of mine, who's written a very good book called Magic in Practice, which is a book for health professionals and communication. And the four things that are really important for mental health really are things like having structure to your day. So, you know, if you normally get up and go to work, and you're working from home, for example, that can really throw your structure out. So having structure, having things in place, some exercise, making sure that you eat properly and you sleep properly as much as possible, and also, you know, this social connectedness. So that may well be, you know, checking in with people online, or being creative about how you check in, basically. And
just asking more about the sleep, Liz, because my Facebook feed is full of GPs that can't sleep because of coronavirus, and I must say I am in that category too.
yes, I have been as well.
How on earth do we sleep at a time like this, let alone our patients? I mean, it Twitter as well. You know, all these overnight tweets from people who the current situation is really impacting on their sleep. Any tips?
Any tips? Oh gosh, right. So I mean, the thing with sleep is, of course, the buzzword is sleep hygiene. So it's things like, I mean, when the body doesn't feel safe, it's much harder for it to sleep, because I mean, that's evolutionary kind of makes sense, doesn't it? In terms of, you know, if we think there's a tiger running, it's the fight and flight response is more likely to be switched on. So it's things like having a routine, reducing caffeine, doing some sort of relaxation type exercise. You know, that could be a mindfulness based thing. No screens for, you know, in the hour before bed, because the blue light tends to keep people awake.
I think that's a massive issue at the moment, isn't it? You kind of read the news, you see the new Italian death statistics, and anxiety is through the roof, even if it was the day before. Yeah,
the stuff on the yeah, I mean, staying off the news. I mean, I think Caroline Walker was talking about this for they've done a really good blog for Red Whale, which is the GP update course, and essentially, you know, checking the news a few times a day maximum. And how many feeds do you need to be in? I mean, I've left a few, actually. I'm not going to mention which ones they are, because they are really sort of we're all doomed type thing. And I don't want to read too much of that, if I'm honest, because I don't find it helpful. So I'm being quite selective about what I look at the moment, and trying to kind of do things like do my garden, and, you know, get close to nature in my garden. Not supporting social distancing, not in the Yorkshire Dales, not in North Wales. And just trying to keep things as kind of simple as possible, really. You know, when I'm talking to family members, you know, really listening. And if I happen to talk to the neighbour over the wall, just really listening to what they're saying and really savouring that social connection, because it's just made me so much grateful. Because I think we just take so many things for granted until they're taken away, don't we? So what else can I tell you about sleep? You know, if you're lying in bed at night ruminating and thinking, get up and do something, because essentially the worst thing you can do is sit in bed all night and think, because that tends to just force more stress into the body. Yeah, I mean, the other thing is just to kind of really accept how you feel at that moment. So the more you try to get to sleep, often the more stress that brings into the body, and the more likely you are to stay awake. So an acceptance of the fact is often helpful as well, which is paradoxical, I know.
Actually, no, I've tried that, and that makes a lot of sense to me, going, it doesn't matter if I'm awake. I will get enough sleep. I will still function in the morning. I have been a health officer. I have had 2 children. I can do this. And actually, by not stressing that I'm still awake, it helps me go to sleep. Like you say, it's paradoxical, but it actually makes a really big difference.
Yeah, you're wanting to reduce tension in the body as much as possible. So acceptance.
Another thing I swear by is sleepy tea. Are you familiar with sleepy tea?
Oh, I think I've had that at your house, actually. Yes.
So really, I think it's called Nighttime Tea by Pucker Teas. You can buy it in Tesco. Other supermarkets are available, but I haven't found any other brands available. And again, it's just kind of herbal, and I don't know, I find it really helpful. I've recommended it to a lot of patients as well, and nobody's complained. So maybe it is. Maybe I don't know if it's psychological or not, but it all helps.
I suppose the other thing I was thinking about with this is just going back onto things like medication supply and practical things like that, just changing the subject completely. So we're using electronic prescribing quite a bit for patients.
Have that in Wales. We don't have it in Wales. So what do you do with it when you have it, other than make Welsh GPs very jealous?
Well, they don't really have it in Ireland either, I found out today. So what we do is essentially we ask the patient to nominate a pharmacy. And if we're worried about their suicidal risk, then we will issue. Generally, what I do is I ask them to go and get a prepayment certificate, because otherwise it gets very expensive.
We don't have to pay for prescriptions though, so at least that's one.
No. No. So then we issue. We might issue 4 weeks post-dated or something like that. Okay. So that they can kind of, you know, they can only pick up a small amount each time. And actually, you know, I think patients often like that in some respects, because they feel that we care about them enough to do that. I think the key is actually to get across the impression that you're trying to help, and you're not, judging them for their behaviour, or, treating them like a child. It's actually, well, how can we help, improve this? And again, that ties into them agreeing with it, and that sort of allows them to make choices. I think choices are really important, and to feel sort of part of the decision and feel empowered. We also often get, with the patient's consent, if it's helpful, is to get a family member on board who we can contact if we're concerned, with the patient's consent, basically. So that can be useful, or they can contact us.
And what would trigger you to contact them?
Oh, I suppose it would depend. I suppose it would depend on the behaviour of the patient, really. So if the patient was kind of the type of person who, when they sort of, shut down and wouldn't speak, and we would have trouble actually making contact with them, which is actually quite common. I think we would, and we knew that they had a good relationship with somebody, or we knew that they, had a person that they trusted. We might have the discussion with the patient then and say, actually, is there any way that we could, is there anyone else that we could contact? I think it's trying to get away from that idea that we're sort of watching you, or we're checking up on you, or we're, being like Big Brother, but actually saying, well, we care. Is there somebody that we could contact, and being very specific with the patient as to when you would contact that person. Okay. So that they're not, thinking that it's kind of a bit of a sort of a watch fest, as it were. Because I think that,
about them and you're behaving as you would for anybody you care about, in a way.
So we sometimes do that with the students. We try not to, actually, because we're trying to treat the students like adults, really, as opposed to kids. So we're trying to kind of get them to, what's really important is that they feel they can make choices and they can talk to us about what they want to. Because it doesn't, otherwise it can feel a bit like a battleground where they're saying, well, I want to die, and the doctor saying, no, you're not, I'm going to keep you alive, type of thing. It's got to be
an adult space and not go into the adult child.
Yes, absolutely. The Burns transactional analysis, absolutely. And a lot of I mean it's about, and being respectful. There's a very, very good, I should do a plug for a lady called Caroline Spring as well, who has a free course on suicide prevention. And she made it free about 3 months ago, and I think thousands of people have downloaded it. And Caroline is a lady who has been diagnosed with dissociative identity disorder, or DID, from many years of abuse, and she's quite open about this on the website. So she's not a kind of a doctor or someone working within the NHS, but she has produced this online course, which is really, really interesting and very helpful.
Well, if you put a link to that in the comments as well, so if anybody wants to follow up on that resource, they'll be able to find it.
Yes, yeah. The other thing that I think is useful to say, and this is the last thing that I'll say, is that one of the things that can really help people when they're isolated and they're kind of stuck in their own heads and they're, they're thinking and ruminating, is being part of something bigger. And I was thinking about this, and that could be, getting them to if they're part of a religious group, or experiencing, experimenting with spirituality, trying to kind of be part of something, bigger. It could be helping or volunteering in some way. A lot of the students because basically the university hasn't quite closed in Birmingham, but it's sort of reduced its operations. So a lot of the students are kind of either going home, or some of them are hanging around. And a lot of them are mobilised into groups, and they're helping the community in different ways, and being part of the solution, really. So they're either delivering food, or they're picking up prescriptions, or they're checking in with people. And if they can't physically, go round and with the social distancing, they're checking up with people on the phone and that kind of thing. And it just kind of gets people out of their own heads, really, and helps them be part of something bigger, and just give back, really. And it's so important. that this sort of thing is a great leveler, I think, and it affects us all, doesn't it? We're all part of the human race, and I think paradoxically, it may well be a way of actually building connections.
Well, it's like that whole wartime spirit people talk
Yeah,
about.
yeah.
Like everybody on my road has been chatting 2 meters apart, I have to say, and we set up like a street WhatsApp group to support each other, and it just a road I've lived on for 10 years and not felt very connected with most people. Suddenly, that sense of community is coming together. And I imagine for a vulnerable, lonely student, suddenly developing that sense of community and sense that I matter and my contribution can make a difference, that must be enormously powerful and beneficial for mental health and well-being.
Absolutely, absolutely. I mean, I was just thinking today when I went in to do the walk-in centre, which not many people are walking in at the moment, I suddenly thought, well, actually, I feel, yesterday I felt quite anxious, actually, but today I thought, well, I actually feel like I'm doing something, and I feel like I'm part of something bigger than me. And it was really, it actually really helped. It was good. Yeah, I mean, that was really all I wanted to say. Unless you can think of something else.
No, I think that's enormously helpful. And I guess what I'm taking from this is the fact that yes, we're doing it through different medium using the video, but actually this is just what we do as GPs, and we already have the skills to do this. It's just doing it using a different medium. And I think for me that's the take-home point from everything you said. There's no magic solution. It's just doing what you do. And I guess it's the thing I love about being a GP, because what we do really matters to people and makes a difference.
Yeah, it's not rocket science, to use an age-old cliche. You already can pick up the signs. They're no different on the video, and to be honest, on the phone.
Mm-hmm.
And the management of risk, I think, is similar to if they're face to face. We just have to be a bit more creative about it in this current climate. And really start thinking about prevention, because it's possible. Well, I wouldn't say possible. I would say maybe quite likely that, if there are staff from the mental health teams isolating, they're not going to be at work. No. And so there's not going to be as many people on the ground. Something else I'd say. The other thing is trying encouraging patients not to make big changes or kind of big life decisions at the moment. I had a patient the other day who wanted to come off an antipsychotic now. And because the mental health team had said you should come off it now. And I had to say to them, look, I really don't think that's a good idea. I think you need to, I'd strongly suggest you stay on it for another 2 or 3 months, because actually, if there is a relapse, or if hopefully not, but if things do get difficult, then at least, when we've got more services on the ground, then it's easier to manage, isn't it? And this patient was okay with that. So that's really important. Just don't try and encourage people to stay, to keep things really simple. And something else. The other thing I would really recommend, this is point number 3, is something called Future Learn. Have you come across this?
No, what's Future Learn?
So Future Learn is a paid and free platform with loads of different courses on it. And they're all, it's quite addictive actually. But they're all kind of courses that, good quality courses that have been produced by people in universities all around the world. And they're all sorts of different. You can even do one on the COVID pandemic if you want to, but maybe not.
Not going to help my sleep issue.
No. But I'm doing one at the moment on mindfulness. There's a really, really good free mindfulness course by Monash University in Australia, and I'm also doing one on literature and mental health, which is to do with different types of literature and how it can help with mental health problems. And they're really good. It's just absolutely brilliant, and they're free, most of them.
That's amazing.
So a big plug for Future Learn. So that's a good one. And I think the Open University have got some free courses as well on their website. So So that was kind of really all I wanted to say.
Well, thank you so much. I think that gave a real insight into far more than just the video consulting, but actually I feel I've got some useful tricks up my sleeve now to pull out when I'm consulting with patients with mental health problems. So thanks again. If you can just pop those links into the comments section, that'd be brilliant, because people can then just click on them and find them. And I'm going to end this call, so I'm going to vanish, and the rest of you can get to the end of the video. Well done for making it this far. And I'm going to get it uploaded to YouTube now. So thanks again for listening. And please do in the comments section, say what you'd find helpful in terms of videos about video consulting. I know people are very keen for something on how to assess COVID patients and how to assess the respiratory system on video link. So working on that one, but just whack in the comments what you'd find helpful. So thanks, Liz, and thanks for listening.
Thank you. Bye. Have a good evening. Bye.
Bye.
Hello.